Okay, perfect. So I'm going to go over some high yield obstetric emergencies and how you can help manage this if you encounter them out in the world. So, why this matters, especially in rural EMS or emergency medical services. 59% of rural US counties are maternity care deserts, which means there's no hospital OB, birth center, or OB provider in the area. On average, there's 33 miles as the average travel distance to the nearest OB hospital for residents in these rural maternity care deserts. And 500 plus US hospitals have stopped delivering babies since 2010, which means about 1 in 4 rural hospitals have lost OB services from 2010 to 2022. And I think that number is rising. And about 80% of US maternal deaths are considered preventable. So early recognition and early transport can certainly save lives. So the bottom line is if you are in one of these many calls and situations, the immediate response, especially in the first 30 minutes, can be really important. And preparing for intervention is also important and being able to safely transport them to a hospital with OB services. Um, so I think that it's important to remember the physiology of pregnancy because it certainly changes. After about 20 weeks, and you're wondering to yourself, maybe, how do I tell if someone is 20 weeks? You can take a quick OB history that I'll get into in just a moment, but a general rule of thumb is, in general, 20 weeks, the uterus is measured at the level of the belly button. And so if you're looking at a pregnant individual and you see that their uterus is around the level of their belly button, they're probably around 20 weeks. At 20 weeks, the uterus is larger and can compress the IVC. So it's important to either displace the uterus and move it off to the left, or have them a little bit tilted, or even you can put like a roll of towel underneath them to bump them to take some of that pressure from the uterus off of the IVC. They also will have a higher heart rate that is normal and a lower blood pressure. However, that also means that shock can be hidden until later on because the body is compensating for this. Um, Pregnant patients also desaturate fast. And so it's also good to remember that you should be actually giving oxygen early and probably intervening earlier to protect their airway as well. And our goal SpO2 in pregnancy is actually greater than 94 for this reason. Blood volume is also up around 50%, which means that they can lose a lot before their vitals start to change again because their body is compensating. And there's also massive uterine blood flow once they get to term, which is anything after 37 weeks, where there's about 600 milliliters per minute of blood flow to the uterus. So you can imagine how quickly someone can end up in a hemorrhage if they're bleeding at term. So really helpful high yield questions to ask your pregnant individuals is how far along are you, how many weeks you are, what their due date is. And you can do some quick math to figure out how many weeks in gestation they are. A lot of patients will report their pregnancy dates in months. Um, in OB, we use weeks just because it's a little bit more helpful. But if they give it to you in months, then you have a general idea. There's also a 3 trimester system in pregnancy, up to until 14 weeks is the first trimester, 14 weeks to 27 weeks and 6 days is the second trimester, and then 28 weeks through 40 weeks is the third trimester. It's always good to know how many pregnancies they've had or number of births, and if they've had a previous C-section, if they've had any vaginal bleeding at all in the pregnancy, if they've leaked fluid, like the bag of water might be broken. And if so, it's good to know what time that was, because timing of that can help us evaluate for their risk of infection. and what color it was. If the color is like a very thick yellow green type of color, that's called meconium. And that is an indication that the fetus may be under distress. It's always good to ask if they're contracting and when that started, how often or frequent the contractions are, and if they feel an urge to push, if they feel fetal movements, and or decreased fetal movements or no fetal movement at all. That would be concerning. And if they are feeling pain, where is the pain? Is it constant? Is it somewhere else or with contractions? And then red flags to always keep in mind are elevated blood pressures, which we'll get into if someone has twins or triplets or multiples, if someone's not had any prenatal care. And we'll also get into what some concerning symptoms may be that should alert you for something called preeclampsia. So here is a framework to try to use for should you stay if delivery might be imminent, or should you go and load them into the ambulance and take them elsewhere. So signs that delivery is imminent is if they're already crowning, you can see the head coming. They're probably about to deliver. If they have a very strong urge to push or are bearing down, if their contractions are less than 2 minutes apart, there's no break in between. If the perineum is bulging again, that's when you'll start to see that the head is coming out. Usually patients will know, and they'll maybe, especially for someone who's had prior vaginal deliveries before, they'll know when it's time to push or when the baby's coming. And at that point, you should just get ready to deliver on the scene or en route if you're already in the ambulance. An in-between phase would be we're not crowning. Contractions are further apart than less than 2 minutes, but they are still contracting frequently. If they have any bleeding, high blood pressures, if they've had a seizure, if you see the umbilical cord, or can somehow tell that the baby is not head down, any mother or fetal instability, they should be transported to an OB-capable facility as soon as possible. And then always call ahead to activate OB and PEDS teams. Pick the right destination, not necessarily just the nearest ED. There's sometimes a lot of freestanding EDs that have no obstetric services or EDs without any obstetrician there. Now, sometimes it's just about getting them to the nearest ED and then transport again from there, but try to have a map of hospitals and emergency departments and what their services are so you know where a good place to take them might be. And then consider airtime, distance, and travel time for critical patients. And in obstetrics, timing is always very important. So I already mentioned we want to know what time the bag of water broke, what time the bleeding started, what time the contraction started, or if there is an emergency like the cord coming down, what time that was and how long it's been. So moving into our first OB emergency is postpartum hemorrhage, which is one of the most common and is the leading cause of preventable maternal death. So it's really important to recognize a postpartum hemorrhage. So technically a postpartum hemorrhage is any blood loss greater than 1 liter, and that includes both vaginal and C-section deliveries. Traditionally or beforehand, it used to just be 500 for vaginal delivery and then 1 liter for a C-section, and that no longer is the case, and it's 1 liter for both, and that's what classifies a postpartum hemorrhage. However, given what I had just said about how much blood flow is in the uterus per minute, things can turn into a hemorrhage very quickly. So if you're anticipating even about 500 blood loss, you should already start getting ready to think about postpartum hemorrhage on your differential. The most common cause of postpartum hemorrhage is uterine atony, meaning the uterus is not contracting as it should to help stop bleeding. And if anyone's ever felt it, a contracted uterus feels really firm. It's a very strong muscle, and you can actually feel the difference. Versus if it's not contracting properly, it may be very soft and what we call boggy. And you'll be able to physically feel this even just abdominally on the patient. Signs of hemorrhage would be pallor, their blood pressure is dropping, and their heart rate is rising because those are physiologic signs that their body is compensating for this hemorrhage. Um, and it's important to act really quickly, especially in the postpartum setting, given all of the rapid blood flow to the uterus. So first thing you can do is a firm fundal massage. That would mean just placing a hand on top of the uterus and massaging it. And you have to be pretty firm. And you should be pushing downwards on the uterus over the abdomen. You can also do something that's called bimanual massage, where you place your hand in the vagina and another hand on the uterus on the abdomen and are massaging it back and forth to help the uterus firm up. And then we have a lot of medication options to help with atony. Pitocin or oxytocin is one of the main things we go for first. In the hospital setting, we'll give it IV. However, you can give it intramuscularly. The intramuscular dose is usually 10 milligrams or 10 units, excuse me. The maximum dose of Pitocin that one could safely use is up to 80. And so if you need to give more than the 10 because you have multiple doses, then you can give that if you're not seeing a response. There's also other uterotonics called Methergin. And Methergin is something to avoid in people who have a history of high blood pressure, preeclampsia, because Methergin has a side effect of increasing the blood pressures. And another uterotonic we use is called Hemabate, and that also is contraindicated in people who have asthma. And misoprostol is another one. Methergin and Hemabate are both injections that you can administer, and misoprostol is a tablet. That tablet can be administered either vaginally, rectally, or buccally, and they just dissolve it in their cheeks. So depending on the situation, think about route of administration with misoprostol. TXA is not a uterotonic, so that means it's not going to help with the uterus contracting, which is ultimately the cause of the bleeding. However, it can help in a hemorrhage. So it's very reasonable, and we give TXA all of the time. It's just good to remember that it's not going to help with the atony or the uterus contracting.
Can I ask you
And
a quick
again,
question
oh,
about
yes, please
TXA?
go ahead. Yeah.
So,
Uh-huh.
just for a little background, I don't know if any, certainly not many agencies are carrying Pitocin. It in Colorado, at least I don't know about the rest of the audience here because I know we have people from everywhere. But for TXA, and certainly not of the other stuff. But for TXA, what dose do you guys use? Do you use 1 or 2 grams?
You can start with a 1 gram.
Okay, awesome.
Yeah,
Thank you.
we typically do 1 gram. But if you need to redose, then you can.
Perfect. Thank you.
Yeah, of course. And then just another point, don't wait for an exact blood count. Like, don't wait until you're already at a liter to start acting. So if you have a lot of bleeding that you think is already more than 500 milliliters in the beginning, it is safest to go ahead and give these meds and act quickly first, so you're not trying to play catch up in an already hemorrhage. And then in terms of safe transport, you should have 2 large bore IVs. If you have fluids, you should give fluids. Like I said, call ahead early and say we have an OB hemorrhage, and continue to massage the uterus and reassess as you can. Okay, so for thinking about preeclampsia, eclampsia, or severe hypertension, so preeclampsia is on a spectrum of hypertensive disorders of pregnancy. On the lowest end of the spectrum is something called gestational hypertension, which is diagnosed anytime after 20 weeks of pregnancy and is diagnosed by what we call mild range blood pressures, which is a systolic of 140 or greater, or a diastolic of 90 or greater. And we diagnose that based off of two of those mild range blood pressures 4 hours apart. and they don't yet have any end organ damage, and so they do not have extra proteins in the urine. The next step up from gestational hypertension is preeclampsia without severe features, which we diagnose similarly, but the main difference between that and gestational hypertension is we start to see extra proteins in the urine because of inflammation in the kidneys that can occur with this. And then the next step up in terms of the risk is preeclampsia with severe features. And there's a lot of ways that you can develop severe features, but the most common severe feature of severe preeclampsia is severe hypertension. So in obstetric standards, that means a blood pressure of 160 or greater systolic or 110 or greater diastolic. And we time it every 15 minutes. So we call it a sustained severe range blood pressure if they have one and it is still in that severe range 15 minutes later. And that warrants immediate treatment with immediate release antihypertensives. If you don't have IV access, you can give oral nifedipine. We usually start with 10 milligrams and then we recheck the blood pressure in 20 minutes. If it's still severe range, then you can administer 20 milligrams of immediate release nifedipine. You recheck the blood pressure in 20 minutes and you go from there. And then you may need to switch to another agent if that is still not bringing down the blood pressures to at least a mild range. We also use IV labetalol. The starting dose with that is 20, and then you can go to 40, then 60, and then 80 is the max dose of the IV labetalol that we would use. And if you're still in the severe range, then you can give IV hydralazine, 5 milligrams, and then 10 milligrams if you need to. But that should all be under the guidance of an OB, hopefully. But if anyone carries oral nifedipine, that's a very easy one to start with. That works pretty well.
There's a question in the chat. Josh,
Oh,
are you asking like is that right upper quadrant pain or are you asking kind of the pathophysiology of that?
No, just didn't know what RUQ was.
Oh yeah, right upper quadrant.
oh,
Sorry.
I'm so
Okay,
sorry.
cool.
Yes,
Thanks.
I'm sorry. That means right upper quadrant pain. Thank you. Please ask questions. Um, I missed that. I can't see the chat while I'm in presenter view, but if you could just call out if you have questions.
I can keep an eye on it for you too.
Thanks, Dr. Farkas. Okay, so right, RUQ means right upper quadrant pain that is constant. So there are also symptoms of severe preeclampsia. And symptoms would be an unremitting headache. That means a headache that does not go away despite treatment, vision changes, and right upper quadrant pain, and then new or sudden onset shortness of breath or chest pressure. That could be a sign of extra fluid buildup in the lungs. Preeclampsia causes extra fluid buildup in the whole body, but it can pool in the lungs, and then they can become unstable from a respiratory standpoint. And then after you have severe or preeclampsia with severe features, the most severe version of it is eclampsia, and that's when you have seizures. The people most at risk of seizure are those who have the neuro symptoms, so headache and vision changes. And sometimes we see that even those people, their blood pressures are not too concerning. They're not in this severe range, but they have this headache and vision changes. And our research has found that they're the most likely ones to have a seizure. However, if someone is meeting any of the criteria for severe preeclampsia, they should be put on IV magnesium. IV magnesium sulfate is what is used to try to decrease their risk of seizure. So it's always safest to just go ahead and put them on it and start it. Though contraindications to IV magnesium is fluid buildup in the lungs. So use with caution if you notice that they're working hard to breathe and have low oxygen levels. So if someone has a seizure from severe preeclampsia or eclampsia, remember your ABCs. It's good to protect your airway. Move the patient to a left lateral tilt, or get them on their side, and pad the bed, pad wherever they're near, and just, try to remove things that are going to be in the way or remove things that could injure them while they're seizing. Give magnesium. If there's no IV magnesium with you, you can give intramuscular magnesium. And the dose for that is 5 and 5 in each butt cheek, so 10 total. You can remember it that way. And if their seizure is still prolonged or recurrent, that's when the next step would be administering a benzodiazepine. In terms of your transport, these people can start to have, like I said, if they're having the vision changes or photophobia, IV magnesium can also cause these things. So generally, patients prefer dim lighting, less noise, less stimulation. Make sure you have IV access, you're protecting your airway. And again, call ahead and say that this patient's had a seizure. We're concerned about eclampsia or severe preeclampsia if they meet that other criteria. Okay. Shoulder dystocia is another type of OB emergency that is very common. Shoulder dystocia is when the head delivers, but the shoulders get stuck. Usually, this is seen in people who have really large growing fetuses. But we're honestly pretty bad at predicting who is going to be at risk of a shoulder dystocia. So, the most common way to predict it is if someone's had a history of shoulder dystocia. So, I would add that to your questions for your OB patients if you're concerned about an imminent delivery. So that way you can be prepared for it if it does happen. So, like I said, the head will deliver and then the shoulders get stuck. It's important to move really quickly because every minute matters because the neonate would be suffocating during this whole time. They're not getting oxygen to their brain. Um, you can start to see something called the turtle sign, which is where the head is delivering extremely slowly and even starting to do this kind of like rocking motion back and forth. That would be concerning for shoulder dystocia. And if you see that, you can already start getting prepared. And the best thing you can do is already put them in a position called McRoberts, which means you pull their knees all the way up to their chest and keep them out to the side to open up the pelvis and give more space. And then you can also, and then the most important thing is you tell the patient to stop pushing. So, just like in all things OB, timing matters. So if you recognize the shoulder dystocia, you ask the patient immediately stop pushing. You ask someone to be a time recorder and say, please start the clock and call out every minute that it's been. And then you should recruit other people in your team to start to help you with these maneuvers. So someone can help pull knees up to the chest. You can do suprapubic pressure, which is someone can take their fist and place it right above the pubic bone and put downward pressure. It's important to distinguish this is suprapubic pressure, so right where the bladder is, and never on top of the uterus or where the fundus is. That will make it worse because it'll make the uterus contract down around it. And then you should not pull hard on or twist the baby's head or neck trying to get them out. Um, Other things we do are different maneuvers called Rubens and a wood screw, which is where you would place your hands inside and try to rotate the shoulders, trying to find a different vector in the pelvis. Another maneuver we do is called delivering the posterior arm, which means if a baby's in there like this, the arm that is closest to their bottom, you try to feel for around their elbow and pull their arm out like this to try again, it's just about physics and trying to get the right vector to then deliver that baby. Um, Rarely we may also need to cut an episiotomy, which means you make a cut with scissors on the perineum, on the skin, just to allow for more space, really so that you can get your hands in to help do these maneuvers to help deliver the baby. And then another maneuver is to put the patient in Gaskin's position, which means they're just on their hands and knees, so they can flip over and be on their hands and knees. This also can help open the pelvis. And then have neonatal resuscitation gear ready. like I said, it's important to have a timekeeper, and then you can document which maneuvers have been tried and how long it has been. Any questions about shoulder dystocia? Okay.
Oh, there is a question
Oh, there's
a
a
little
question.
bit on magnesium. Not sorry, I think I
Oh,
was
yeah.
slow with that
Yeah.
in the chat. So the question is, could you touch more on pathophysiology of why magnesium is our first line for eclamptic seizures and not just straight to benzos? And then a question about is it pretty effective usually?
Yes, magnesium is very effective. They did a study looking at other anti-epileptics compared to magnesium. Um, for preeclampsia specifically. And in those randomized control trials, they have found that magnesium has the greatest efficacy compared to the other anti-epileptics like benzodiazepines and Keppra. Um, I don't actually know, the pathophysiology of preeclampsia is already poorly understood. What we do know is that it's caused by the placenta and by like abnormal vasculature in the placenta, causing a very high resistance system in the placenta. And so treatment ultimately for preeclampsia is delivery because you need to deliver the baby and then deliver the placenta because that's what it's caused by. So there's not a lot that we can do when they're currently pregnant. So if someone comes to us with a seizure, really no matter the gestational age, we would recommend delivery for maternal safety and maternal benefit. So I don't know exactly how they studied magnesium and like why they picked magnesium compared to something else. But we do know that magnesium works better than benzos or Keppra for eclampsia. Now, some people may have a known seizure disorder, and so any pregnant person, I think if possible, to try to get a history from the family. It would be important information to know, do they already have a known seizure disorder and they're having a seizure because of their seizure disorder, or we're concerned about preeclampsia. Um, and getting that history from the family can be helpful there because if they're not meeting this other criteria for preeclampsia, then it might just be that they have their known seizure disorder and you need to give them their anti-epileptic meds. But when in doubt, just start magnesium. Any other questions around magnesium? Okay.
Actually, can you talk a little on, we have some prolonged transport here.
Yeah.
Can you talk a little on what to watch out for after magnesium administration?
Yes. So if transport's going to take a long time, magnesium is not a benign intervention. So people on magnesium can, like I mentioned, develop fluid buildup in the lungs because of the magnesium also. So it's important to measure their oxygen levels during transport. It's important to cycle their blood pressures so you can keep an eye on their blood pressures during transport and know if you need to treat them with immediate release antihypertensive medicines. Um, and then you can also check someone's reflexes in preeclampsia. We see that you can become hyperreflexic, meaning they have like a much stronger reflex compared to normally for them with preeclampsia. But magnesium can also diminish your reflexes. So it's good to try to get a baseline exam at first so you know what this person's reflexes are like before you start the magnesium. And then when you're giving the magnesium, you should keep checking their reflexes because oftentimes losing their reflexes or having diminished reflexes is one of the first signs of magnesium toxicity. Um, and so if they have lost reflexes, I would be concerned about magnesium toxicity, and you would need to either turn down the rate of the magnesium, check a blood level of the magnesium, and just turn off the magnesium. Because preeclampsia can also impact the kidneys and magnesium is filtered through the kidneys. If they're already having poor kidney function because of their preeclampsia, then they're more at risk of magnesium building up in their body, and then they could experience toxicity from the magnesium. Our goal level of magnesium for preeclampsia seizure prevention is anywhere from 4.8 to 8.4, which is much higher than a normal goal dose of magnesium for somebody. But we can start to see even more significant risks with magnesium, like pulmonary edema or fluid buildup in the lungs, and then even cardiac impacts as well. So it's important to very closely monitor their vital signs, check their reflexes, and keep an oxygen level on. Okay. Umbilical cord prolapse is another OB emergency. This one is far less common. The risk of an umbilical cord prolapse is 0.7%. So this is a pretty rare event, though it does have significant risk to the fetus if it does happen. So what that means is umbilical cord prolapse can happen when the umbilical cord drops through a dilated cervix. And again, then the baby's head or another part could compress the cord, and then they're not getting oxygen to the brain. And in worst cases, you could have a fetal demise or death. So it's most common when there's a preterm baby because they're much smaller, so there's just more space for the cord to drop. It happens when the water breaks. So while the bag of water is intact, it's holding everything in. But if it breaks and they're preterm, there may be more space for that cord to come down. And especially if they are breech, which means butt or feet down instead of head down. Because usually the head is big enough that it can just take up space in the pelvis and prevent the cord from coming down. But babies who are breech, their butt isn't quite as large as their head at that gestational age, and their feet obviously are not as large as their head. And so there can be a lot more space for the cord to fall down through the cervix and even fall down into the vagina. Um, so if the patient says, I feel like there's something in my vagina, it is good to check. You can even just feel it with a manual exam. And if you feel something pulsing in the vagina that feels like a cord, then what you do is you announce to the room, we have a cord prolapse. And whoever checks the patient should then be the one to stay where they are, and you should elevate the fetus's head or foot or whatever it is that is compressing the cord to try to relieve the pressure on the cord. So that way the baby can still get blood flow and oxygen to the brain. So, and then you unfortunately have to stay that way through transport. This is seen as like a true OB emergency. When it happens on labor and delivery, we're all running to the operating room to do a C-section within minutes. But unfortunately, if it happens out in the community, really the best thing you can do is just elevate the fetus's head, transport as soon as possible, or elevate whatever presenting part there is. You can also try to put them in that McRoberts position with their knees to their chest and put them with their head steeply down. It's called Trendelenburg position, which is basically like upside down, to try to put them upside down. So hopefully maybe the cord and everything like moves up towards the top of the uterus and stops putting pressure on the cord. Sometimes people can also put there's like an inflatable balloon that you could put in there, but that would be like a device that you would have to have on hand. So it's best to just use your hand. Don't push the cord back inside because manipulation of the cord can also cause compression of it. So just don't touch the cord, just elevate the head or the part that's on the cord around it off of it. And then tell the mom to stop pushing. This one, if they are pushing and they're crowning and the head is about to deliver, then you should just deliver the patient because ultimately that's going to be the safest thing for the baby. But otherwise, you would have them stop so that way you can just elevate and get pressure off of the cord. And this, like I said, is an OB emergency where you have to go to the OR for an emergency C-section. Any questions on cord prolapse? Okay. So bleeding in pregnancy is another OB emergency. Most commonly, bleeding in pregnancy is caused by something called placental abruption. What that means is the placenta can start to tear off the wall of the uterus a bit, and that tearing can cause significant bleeding. Another common reason is more like in the 15 to 20 week gestational age range. The uterus is doing a lot of growing, and as the uterus grows, the placenta will often move and grow with it, and that moving of the placenta process can also cause bleeding. But it's safest to assume that the placenta is tearing off the wall of the uterus. Vaginal bleeding in pregnancy is extremely unpredictable, and it's very hard to know. It's nearly impossible to know. Sometimes people just bleed once and then never again in their pregnancy. And then sometimes people have regular daily chronic bleeding. A really important thing to ask people is where their placenta is, because if the placenta is covering the cervix, that's called a placenta previa. So the cervix is the bottom part of the uterus, and it has two openings, an internal opening that goes into the uterus and an external opening. And then the external opening sits in the back of the vagina. When we're checking patients in labor, that is the cervix that we're checking on our exams. So when the placenta is completely covering the cervix, that means that there can be a lot of amount of blood loss if there's any bleeding in the pregnancy, or if the patient starts having contractions, if they start laboring. Having a placenta previa is not safe to have a vaginal delivery because they can have life-threatening hemorrhage. So all placenta previa patients should be delivered by C-section. And so if you are evaluating someone who has vaginal bleeding in pregnancy, you should always ask them, do you know where your placenta is? Do you have a placenta previa? So that way we know if it's safe to wait a little bit, or if they need to immediately, again, go to the operating room because we're concerned about the bleeding and where the placenta is. We already kind of talked about postpartum hemorrhage, so it would be similar to this. But placenta abruption, that blood loss in the uterus can be very irritating to the uterus. And so it can start preterm labor if it happens, because the uterus gets so irritated with blood. It'll just start cramping and contracting because the uterus is just one big muscle. So that's how it responds to irritation. And we find that if that does happen, the delivery process is usually pretty quick. And also, it can cause significant distress in the fetus. So, it would be important to monitor the baby's heart rate during this and during transport, because all of that blood also impacts the health of the fetus. And if the placenta is torn off the side of the uterus, then the placenta is not working as well. And so the baby is also feeling that impact and not going to do well. Any questions on what a placenta previa is or placental abruption?
I see a question if a good question. If showing signs of shock, is TXA okay, or is it only for post-delivery bleeding? And I will have you answer that question, and then I will
Yeah.
talk about protocol specific stuff.
Yes. Give TXA. That would be fine. Yes.
Yes, that's a conversation that is probably waiver and protocol dependent. So we can talk more about that offline, Brian, specific to our waiver and protocol. But yes, absolutely clinically indicated.
Yeah. Okay. All right. And so there's differences in how the baby can be delivered vaginally. So a normal head first delivery is the safest way to have a vaginal delivery. The reason for that being is the cervix will dilate to whichever part is coming down first. So if the baby is head down, the cervix is going to dilate to the head. If the baby is butt down or feet down, it'll dilate to that. But for all babies, the head is the largest part of the baby. So what can happen is if they're breech, which means bottom or feet first, is their whole body can deliver, and then their head can get stuck around the cervix. And it's like the baby is suffocating because the head can't pass the cervix. And they, again, don't get oxygen to the brain. So that can, breech deliveries can be really dangerous. The best thing you can do if you are encountering a breech delivery is we are very actually just hands off. We just let the body deliver on its own all the way down to the neck. And then what you can do is you can put a towel around the baby's body, like a sling, to kind of hold up the baby's body and try to flex the chin down so that way it can flex downward and pass the cervix. So that's what this Marcio maneuver is. If you're trained in it, you place two fingers on the cheekbones here to flex the baby's head down so that a way it can pass through the cervix. Um, there are forceps, which are like metal spoons that you can place around babies to help deliver them. And this can be something to help with a breech delivery. They're called Piper forceps, and you would put them straight forward in. And you put the baby on top of the forceps, and it helps again to just flex that head down this way to try to deliver the baby's head. Um, in If that doesn't work, then you can technically make a cut on the cervix to try to give more space and push back the cervix to deliver the baby's head. We try very hard not to do that because the cervix can bleed a lot. And so then you might be running into heavy bleeding, which is also a complication. But, it's worth that to also try to save the baby in this situation so you can make cuts on the cervix. We usually use a clock face to determine where things on the cervix are, and the uterine arteries come down in supply blood from the uterus to the cervix at the 3 and 9 o'clock positions on the clock face. So do not make your cuts there because then you can have serious life-threatening bleeding all from the uterus, and that would require a hysterectomy for control. As the theme goes in this talk, time is critical. So it is important to do these maneuvers and try to deliver the breech baby's head. Similar to the shoulder dystocia, you can do some suprapubic pressure, again, to try to facilitate flexing that baby's head down. In a normal delivery, all you need to do is just support the head as it delivers. We do like to put some pressure on the perineum and also downward pressure on the top of the head once it is starting to be at a large crown. So that way you can decrease your risk of vaginal tears at the perineum, and also tears anteriorly or at the top, because sometimes the baby, if it comes out really fast, can then just like flex their head into the anterior structures, and then that also causes bleeding, is very uncomfortable for patients as they heal. If you see that the cord is around the neck, that's called a nuchal cord. It's very common. Most of the time, you can just deliver the baby through it, and then once your baby is out, you then just remove the cord from over its head, and then you can place the baby on the mom. And so what you do for maneuvers in delivering the baby, like I said, You protect your structures as you're at a large crown. Once the head is delivered, you can just be hands off and the baby will restitute, which means the baby is going to turn its head. And then you can place both hands on either side of the baby's head like a pancake, and you're going to do downward pressure or downward traction gently on the head until you see that top shoulder pop out. And then you can pull the baby up to help facilitate delivering the baby. And then you're going to want to dry, warm, and stimulate the baby. So I always rub the baby's back. You can rub their feet to try to get them to have a good cry. Crying helps the baby express if there's been any fluid in their airway as they've come through the vaginal canal. So crying is a good thing for them. And you can try and look at their APGAR scores to determine, how this baby is doing. No babies in Colorado get perfect APGARs because they all come out bluish purple because of the altitude. So no one is a pink baby when they are first delivered. So if a Colorado baby has a 10 APGAR, I don't believe it. And then after baby comes out, then if safe, we will do what's called delayed cord clamping, which means you wait to clamp the umbilical cord until about a minute, because there's benefit to getting all of that blood to the baby during that minute. And then you can take two clamps, and the really important clamp to have is from the umbilical cord to the baby. So you want to clamp there very tightly, and then you clamp right after that, and you can cut in between, and that will release the baby from the umbilical cord. It is very important to not release that back clamp closest to the baby's umbilical stalk because they can bleed out that way. So always keep the clamp on the baby's cord and the baby, and then cut your segment. After baby's delivered, then we do the third stage of labor, which is delivering the placenta. So to deliver the placenta, you would then place one hand in that suprapubic area right above the pubic bone where the bladder is, and one hand on the umbilical cord, and just apply gentle downward traction on the umbilical cord to try to facilitate delivery of the placenta. It is normal for the placenta to take up to 30 minutes to deliver. Most of the time it happens before then, but it doesn't need to come out immediately. Okay. So it's reasonable to wait until that 30 minutes, and then we consider the placenta stuck. And then if it still didn't deliver, we would have to reach in and go out and grab it and pull it out. But the placenta being stuck would be another concern that also could cause life-threatening bleeding. So it is important to recognize if the placenta is not coming out. Most cases it does. And then once the placenta comes out, so as you're doing your downward gentle traction on the placenta to deliver it, it'll then eventually just come out, and then you can use both hands to kind of twist it and gently pull it out. You don't want to just like grab it and pull it because the membranes can get stuck inside the uterus, and that can later cause complications like infection and ongoing bleeding. So you do want to just let it deliver intact instead of going in to grab and pull it out. And then it's always a good idea to examine the placenta and make sure that it looks like it all fits together, to make sure it would just raise your suspicion. If it looked like kind of torn, you would probably be wondering if some placenta got left behind in the uterus that would need to come out eventually. And then after the placenta comes out is when you should be doing your fundal massage. Massage is definitely not the right term because it is not a massage, because it's a lot of like very aggressive downward pressure on the uterus to help expel blood, and facilitate the uterus contracting. Our protocols here at labor and delivery is to do a fundal massage every 15 minutes for the first hour of delivery. And again, just look for those red flags of the placenta not coming out or postpartum hemorrhage at that time. Any questions on normal delivery or breech deliveries? Okay. Okay. For maternal cardiac arrest, um, I think the really important thing to remember here is, for the most part, you should not be changing your CPR at all for a pregnant person. So you place your hands in the same position. You're going to do the same rate, the exact same depth as you would for someone who is not pregnant. Um, the main thing to consider is if you take a look and it looks like their uterus is at the belly button, that is when it will be really helpful to do that left uterine displacement. So you can have someone truly just place both hands on their uterus and just move it to the patient's left. And they can just stay like that while the rest of the team is doing the chest compressions and CPR. You should never put that bump or tilt the patient while you're doing CPR because it impacts the quality of chest compressions and has absolutely no maternal benefit at that point. So what would be best is they should still be flat on their back with a baseboard behind them, and the other person can then just move the uterus to the side while we do regular chest compressions. Also, we already mentioned this before, but expect there to be a difficult airway and higher aspiration risk, and they are likely going to need oxygen earlier than someone who is not pregnant. And just like how you should be doing your CPR normally, you should also defibrillate normally and place the pads and energy in the typical position. Where CPR is different is the timing. So, and this only matters again if the uterus is 20 weeks or greater. So at when the uterus reaches the belly button or is above the belly button, this is when this timing would be important. We would only allow for in a code, we would only allow for 5 minutes of a rest. And if there is no return, then is when you should consider doing a perimortem C-section. So what that means is you do a C-section to deliver the baby, not for the baby's benefit, but for the maternal benefit to relieve that pressure of the uterus on the IVC. And we also already talked about like blood flow to the uterus. So removing the baby is going to be the best thing that you could do for maternal benefit after 20 weeks in a code. And then, as always, communicate clearly and early that this pregnant patient, again, I would specify with presumably 20 weeks, is having cardiac arrest. If the uterus looks like it's well below the level of the belly button, then there is no indication to do this C-section. Again, because this is just for maternal benefit, not fetal benefit. And less than 20 weeks, the uterus is just not big enough to have an impact here. Any questions on maternal cardiac arrest? All right. So to summarize, it's always important to communicate, give a good handoff, and document. So always call ahead, name what you're concerned about, whether that's hemorrhage, eclampsia, cord prolapse, pregnancy, arrest. Again, how many weeks pregnant they are, how many prior births, if they've had C-sections or vaginal deliveries, what the mother's vitals are. If you have the ability to listen to the fetal heart rate, that would be important. How far away you are in your ETA, or whether delivery has happened or is imminent. Things that can be helpful for our handoffs when we're meeting the team down in the ED for transport is if a delivery happened out in the field, you're if you can get an estimate of blood loss and if the placenta has also delivered or not. And if you think the placenta was intact or if you're concerned that partially it's still in, those are helpful things for us to figure out. Do we need to do more interventions immediately? And then ask for people to be ready, OB, peds or NICU team, blood, and OR is needed. It's always good to give a structured sign out or an ASPR, which usually starts with a one-liner about the patient, their age. For us, we like to know how many pregnancies there are, how many deliveries they've had. We call those G's and P's or gravida and parity, how many weeks they are, any complications in the pregnancy that you know of, like high blood pressure, diabetes, asthma, what the presenting situation is. Always remember to record times for everything, whether what time they delivered, what time the placenta delivered, what time the bag of water broke, what time the bleeding started, what time the shoulder dystocia began. That's all helpful information. If you deliver a placenta, please bring it with you so we can send it to the lab and look at it under pathology. And it's also helpful to give a report about the baby as well. So we have 2 patients. So here's just a really quick summary slide of a main takeaway in all of the things that we talked about. So for postpartum hemorrhage, recognize the blood loss, recognize if the uterus feels boggy or is soft, give fundal massage, give TXA per your protocol. If you have uterotonics, give those. If you have severe hypertension or eclampsia, remember the blood pressure cutoffs, remember the concerning symptoms, particularly headache and vision changes for their seizure risk, protect their airway, give them magnesium. You may need to give them oxygen. For shoulder dystocia, be aware if the head looks like it's taking forever to deliver, get them in the right position, do your maneuvers and record the time. Do not pull hard on the baby's head or the neck. You can make it worse. If you have a cord prolapse, if you feel a cord in the vagina that's pulsing, after the bag of water breaks, you can place the patient in Trendelenburg, which means basically upside down, and elevate the head off of the cord, and they should go to the OR right away. If they have bleeding, think about where the placenta is, if they know if it's covering the cervical os or not. Don't do if they do have a previa, then you should not be doing a vaginal exam, because you could accidentally poke into the placenta and that would cause life-threatening bleeding, possibly. If they don't have a previa or you don't know, again, I don't think you need to do a vaginal exam while you're in transport. You'll be able to see the level of blood loss they've had between the legs or on the chucks beneath them. But previas with bleeding or non-previous with bleeding may need to go to the operating room as well. For breech delivery, that means bottom or feet first. Again, just be pretty hands-off and let the body deliver on its own. And then once the body delivers, place that the body in a little sling and try to flex the head down to deliver past the cervix. If your newborn is not breathing, warm, dry, stimulate the baby, give PPV, keep them warm, ventilate them. And for maternal arrest, remember nothing should change about your CPR. Do not tilt the patient, do keep them flat with the sturdy board behind them. You can move the uterus to the left, but that should not impact your chest compressions. Defibrillator pad should be in the same position. And if the uterus looks like it is at the level of the belly button or higher, and it's been 5 minutes of pulseless activity, then you should do not you as EMS transport, but someone, either the ED provider or the OB team, wherever they're going to, should be doing a C-section. And that's all I have.
Thank you so much. I'm gonna put up our QR code for CEs for you guys and put the link in the chat, but please feel free to ask any questions.